So with our groin assessment, the injury history is very, very important. Okay, so again, I want to know why is these maybe adductors taking excessive load in the first place. Okay, so again, is there anything in the injury history that maybe that person is maybe not happy to tolerate load in certain directions throughout the body, these adductors to do too much. Okay, so that'll be the first thing. Okay, the other thing then with the generic objective assessment, I want to know what tissues that person subconsciously is not loading maybe very, very well. Okay, and again, in the mentorship, we've got this pretty much systemized so that it's very, very easy to figure out that information. Then when we get them onto the bed, just a couple of things now that I'm going to go through in a little bit more detail. Okay, we want to have a good look at their movements, and again, one in particular, obviously the hip internal rotation flexion is pretty important. Okay, so again with Pete here, we've got a little bit of resistance here. Okay, so as he comes up, the point at which the resistance comes on, okay, there's probably going to be some tissues that are going to be contributing to that stiffness or whatever you want to call it more so than others. So at this point of the movement, if I feel the resistance here, Pete's posterior hip capsule, it's not going to be fully lengthened at that point. Okay, so I'm thinking more outer layers here. Okay, what has to lengthen at this point? Okay, so again, these distal fibers of glute are going to really start to lengthen at this point, okay, as they attach into here. So if I want to desensitize anything here, I may be thinking I'm going to start there rather than going straight to my Mulligan belt and start trying to mobilize the hip capsule. Yeah, you might get an indirect response to the glute max, but from my experience, we'll get the person in an hour later. Okay, they'll go to the gym or they'll go to a meeting. I'll grab them, and again, I'm lucky from being in a professional sports setting for so long. I'll grab them, I'll check it again, and usually it's back to square one. Whereas if we go directly, we desensitize these tissues, we reassure the system is safe to tolerate loading, to lengthen, whatever you want to call it. Then the gains tend to stick. So again, we want to try just be a little bit more clinically reasoning rather than just trying to throw crap at the wall and hoping something sticks. Okay, hip internal rotation, again, getting the difference between that and supine and prone. Okay, so again, in hip flexion, adductor magnus is going to lengthen. When we check Pete's hip internal rotation and prone, his adductor magnus is going to be short. So that's probably not going to influence his hip internal rotation as much in prone. Okay, so again, that's good information for me, and I can start to use this information and start to clinically reason a bit. Okay, another big one that I like doing is obviously the abduction. Okay, if they feel pain or where they feel this pull. Okay, where do you feel that, Pete? Okay, in the groin. Now again, you may get some athletes that feel it in a very, very specific spot in the. Again, that to me would be maybe these tissues aren't happy to lengthen at this particular point. Okay, why? Okay, again, we want to ask that. We want to check the difference with both of them. Then we can go on to other tests that you might use. You can go do your neural test if that's what kind of therapist you are. That's fine, absolutely do that. Some therapists might look at the lumbar spine, etc. And then the big thing we want to look at then is the motor output through the adductors. Okay, so usually there'll be three kind of angles of hip flexion that we'll do this. Okay, so we'll usually do it at 0-ish. Okay, so I usually get a fist, I'll put it between the medial condyles, and Pete just squeeze for me. And again, I'm looking for intent here. Okay, so at this point, then we'll bring him up to 45 degrees, and Pete squeeze for me. Okay, good. Any pain with that? Okay, and then I'll usually bring them up to about 90. Okay, squeeze again, Pete. Good. And then any pain there. And if there's a big difference noticeably in one versus another, then that's brilliant information for us. Okay, if all of them are painful, okay, then we're going, okay, maybe we just want to be concentrating on desensitizing the adductors as part of our 20% that we're going to focus on treating the symptoms. Okay, 80% of our focus and our attention is going to be on what's contributed to this pain experience in the first place. Okay, but the big thing here, the nice thing about this is we can start to reason. Okay, so we know from the literature, okay, that 45 degrees when we squeeze, that's a position that's going to recruit the adductors the most. Okay, when we're in this position, we're going to shorten the adductor magnus a bit more. Okay, and then as Pete squeezes, the other thing that we may want to consider here as well, potentially, that I think is pretty important here is the medial aspects of the direct fem as well. So those tissues in the frontal plane may contribute to this as well. Okay, so again, we can cross-reference that. If we think that's a particular structure that we want to take care of here, we can cross-reference that with other tests as our assessment goes through. Okay. Then the big one that I'm interested in especially is 90 degrees, and I always like to go a little bit more past 90 degrees, okay? So as Pete goes up here, okay, I'll get Pete to squeeze, okay, and then I'll usually get him past 90 and I'll get him to squeeze again, okay, and I'll look at the difference in that. Now there's a few things that change in structure here that's important to realize with hips and realize with groins, and that's the influence of the pelvic floor and the diaphragm at that position. So a lot of athletes, especially, they're very, very poor at the 90 degrees or slightly past the 90 degree position. Now, when I bring Pete's knees up, okay, if you bring your knees up here, Pete, what's going to happen here is obviously we're going to posterior rotate the iliums. That sacrum is going to tuck under, okay? But what needs to happen there is the pelvic floor needs to ascend, okay? So can that pelvic floor get out of the way? When that pelvic floor gets out of the way, then hopefully all these other tissues such as the obliques will be able to actually contract. So again, those obliques are going to be able to contract with ribcage depression. Okay, ribcage depression relies on the diaphragm to lengthen, the diaphragm lengthening and the pelvic floor ascending. They're going to go together. Okay, based on, we know this from the literature, especially looking at the respiratory literature. Okay, so again, if this person maybe doesn't like depressing the ribcage, we'd start to think about the optimal length-tension relationships for these obliques and other tissues. And I find clinically myself, personally, that up here, we're more looking at the obliques, or the other big thing here, we want to have good hip flexion. So maybe he's got a poor squeeze here because he's got a poor ability to actually get his hip up into flexion in the first place. Okay, we know about agonist, antagonist, that influence. Okay, is that actually influencing his squeeze here? So very often, I can restore full range of motion in this hip very quickly, or this hip or whatever it is, recheck the squeeze, happy days. Okay, so again, the key thing then I want to do is keep that, and that's where my 80% rehab is going to be important. Where if he was there, if he was really strong there, okay, and he was really strong at 45 and he was really weak here, then I want to make sure that all these tissues, okay, that maybe are going to lengthen here, are maybe a little bit more desensitized. Okay, so again here, the proximal rect fem, I want to make sure that these tissues are tolerating load very well, that there's no protective tone, or there's no kind of perceived threat to tolerate load here. Okay, and again, it's a simple test that I could do to maybe cross-reference that is hold it there, Pete, push up into my hand, okay, because what I'm going to do here, okay, is I'm going to push through Pete's leg. He's going to have to dorsiflex, and then there's going to have to be load tolerated through this knee as well, because as I go like that, I'm trying to flex his knee, so to tolerate load well through here. Once that can keep going, then as I continue to push, he's going to have to resist hip extension, so he's going to have to flex from here. Okay, so we know we're going to put a load through here. Okay, so that test, it's testing everything, not just one particular tissue. Then I can get a little bit smarter. I can go, okay, maybe that anterior medial direction is not tolerating load very well. So let's start to bias that a little bit. Okay, Pete, let's have a look here. Okay, and then that's more lateral, and then let's go here, or sorry, that's more medial. And then we can see that he isn't tolerating load very well here at the moment, okay, if that was the groin pain patient, okay. So that may make a bit more sense then why this squeeze is maybe down, but this one is very, very strong, because at this point here, these tissues don't have to lengthen, okay, so they're maybe not perceiving a threat. Because again, remember, when these tissues lengthen, any tissue that lengthens, they're going to set off receptors, that's giving sensory information up to the spinal cord, that may potentially go up into the higher centers if there's maybe enough of it going up and the higher centers pays enough attention. Okay, so that's something that I would use then to clinically reason what tissues I am going to treat in order to restore that squeeze. Okay, so that's very, very important to be able to figure out what tissues are contributing to this pain. So if Pete has got a different pain experience from 0, 45, 90, brilliant. That's where we have to use our clinical reasoning to actually go about then figuring out what peripheral tissues are contributing to an inability to do this motor task that we're asking them to do. Okay, so again, it's not just adductors, it's not just obliques. There's lots of tissues moving. When I bring that hip to 90, past 90, I guess that posterior tilt, that pelvic floor needs to ascend, okay? If it can't ascend because he's stressed, okay, maybe that's contributing to this, okay? So again, that may be in his history where he's had a lot of loading, either emotionally or physically, and that may have contributed to maybe these tissues not being as pliable, okay, as possible, or as possible, I suppose, is the right word there, if it is. Okay, so that's pretty much what I wanted to cover with the groin assessment. Okay, it's not by no means a full groin assessment, but hopefully that'll give you some information. The other thing that I want to talk about a little bit then is if some patients, okay, that you're going to get in, especially in sport, is they'll have a very strong squeeze, but they'll have a painful squeeze. Okay, so in that scenario, so Pete, if you got to 45, again, we've had this quite a bit where they're painful, but it's very, very strong. So again, if they've got a very, very strong squeeze, that's interesting to me. So Pete may say to me, yeah, I get the pain just around here in this adductor. Okay, so what I would do in that scenario then is I like to actually assess some hair then. So I'll just do one adductor at a time, squeeze Pete, and again, it'll still be strong, okay, but he won't have any pain. So what I would then hypothesize there is that maybe this tissue, when he has to do both together, is maybe doing too much. So then I'll go back to this one and I'll get him to squeeze, okay, so push again, and then usually we may find that there's actually an issue loading these tissues here, okay? So when they do it bilaterally, sometimes I can see that they'll get a pain experience, then I'll do it unilaterally, and that pain experience will tend to disappear. So then what I would hypothesize that maybe that tissue there is doing excessive load to do this task, because this is the task to the brain. This is the outcome I want, squeeze, okay? The brain doesn't really care, okay, how we do it. It just wants to achieve the task. How we figure out what to load, okay, that's going to be going down through the different parts of the spinal cord, the peripheral tissues, and it's going to be influenced massively by our previous experiences to these tissues. So if he had a decreased motor output through this adductor then, what I want to know then is why isn't he tolerating load well through here? Do I have to trace it down? Do I have to trace it up? Is it still a reaction to the pelvic floor and diaphragm? Is it a stress response maybe? Okay, maybe all I need to do is get him to relax. Do a little bit of desensitization of his respiratory system, change his heart rate variability, get that diaphragm moving a little bit more rather than just that constant fight or flight, and maybe that might take care of it. Again, that just depends on your system that you use. You can look at that, okay? As always, a disclaimer, this is just one way of looking at the body. This isn't the only way of looking at the body. I'm giving you an insight into how I look at it, my thought process of this 80-20, okay? And as I said, most of these injuries, okay, overloading, the first question in my mind, what's not doing its job, okay? So we still respect the pathology, we still want to desensitize, we still want to reassure, we still want to make sure that that pain experience dampens down, but first and foremost to me, I want to make sure that what maybe contributed to this overloading in the first place is taken care of, because that's then where I can send my athlete back, and I'm pretty confident that that pain is not going to return again, or that another motor adaptation happens and they start to tolerate load maybe excessively somewhere else in the body, and then maybe an Achilles starts to get a little bit sore or something else. Okay, so I appreciate it's not for everybody this. It's a different way of looking at the body to how I was taught at university. I've had to start to look at it like this because the traditional approaches failed me when I went into professional sport. And as I said, the more that I started to look at it like this, started to clinically reason, and started to work with hypothesis, where I'm trying to disprove my working hypothesis, okay? Kept to a constraint-based approach where I'm just trying to go at one thing at a time, continually to load. So then the next step, the next progression is the next logical progression. It's served us very, very well, especially in the last 5 years or the last 10 of working in professional sport. The more we start to get an understanding of how the body is all working together, how the respiratory system can impact the musculoskeletal system. Okay, so again, they all have to work together in the real world. Emotional stressors, physical stressors, lifestyle stressors, okay, it all impacts on that pain experience.